Dr. Jenny Pham is a Program Director of Biorepository and Laboratory Services for CTSI, the Clinical and Translational Science Institute at the University of Minnesota. Dr. Pham completed her PhD in biology at Harvard University, where she gained experience exploring the ecology and the evolution of bacteriophages. Subsequently, she served as a strain curator for Joint Bio, a joint venture founded by Bayer and Ginkgo Bioworks. In this position, she established a centralized biorepository to support the company's R&D efforts. In her current position, Dr. Pham oversees and strives to expand BioNet, the University of Minnesota's biological procurement network. She works closely with clinical partners to ensure services are effective and compliant. We look forward to hearing from you, Dr. Pham, about her valuable work.
Thank you for the introduction.
Thank you.
All right. And share my screen and then set it up to slideshow. I hope everything looks good. Thank you so much to the Biosample Hub team for having me here today. I'm the program director for BLS, which is Biorepository and Lab Services here at the University of Minnesota. So our team is composed, well, the leadership team is composed of myself. I'm the program director, and our medical director is Dr. Pari Murugan. He is a pathologist, and we jointly lead BLS with 7 other full-time staff members. And then we also work very closely with the Department of Pathology to procure surgical tissues from the OR. So our program is composed of 4 distinct but related laboratory divisions. So we have specimen procurement, which is also known as BioNet. We have a specimen and data repository, histology and research lab, and a digital imaging division. And the goal with these 4 integrated divisions is to provide biospecimen research support from when you're interested in having specimens procured from the hospital, all the way down to storage, histological processing, pathological analysis, and digital imaging for publication quality figures. We've been operating at the University of Medical Center since 1996. There are 3 separate hospitals on our campus. We cover all those sites. And we are a hybrid internal and external service organization. So we work with both academic partners and business and industry. And on average, we support approximately 150 unique research projects per month. So I'm just going to go through each division and give you a little bit more detail and context into what everyone does. So specimen procurement, we have an IRB approved protocol and consent form to consent and collect de-identified surgical waste tissue and matched biofluids from those surgical procedures. With every sample that we collect, we are also able to provide researchers with a very detailed case report that is de-identified, and it includes everything in the patient's medical history up to a year before the surgical procedure where the sample was collected. So that includes patient demographic information, lab results, medication list, treatment history, social history. It's a standardized report that is automatically extracted from the patient medical record. That's another very nice thing about it, because when you're receiving samples from us, you're also receiving the same data set every time. Next is our specimen and data repository. This is a facility where we keep ultra low -80 freezers and also liquid nitrogen tanks. And we store approximately 70,000 archival FFPE and frozen tissue samples. We also have OCT and biofluid inventory, but that's a bit more limited since mostly what we focus on is surgical tissue. There's representation across organ systems, disease indications, and pathologies. We have malignant, metastatic, and also normal adjacent to cancer tissue. We also collect normal tissue from benign conditions. And every sample that is inventoried in our repository before it's released to a researcher, it is QC'd by a pathologist, and we also provide that same case report with de-identified clinical data. We'll talk about our histology and research lab and digital imaging divisions together. So this lab does all of your standard histology processing, like generating FFPEs, cutting slides, standard stains like H&E. We also do custom complex staining like immunohistochemistry, immunofluorescence, and we are able to onboard new antibodies onto new tissue types into that lab and optimize those conditions. The histologists that work in our lab are very talented. They're able to work with animal and human tissue, and they have been expanding into plant tissue as well. We've also started to expand into spatial omics, sample prep, and QC. There's a lot of front-end histology work that goes into preparing the slides that are then run on the spatial omics platforms. We're able to work with those sample types now. We also construct tissue microarrays, and we can also do imaging for quantitative analysis and publication. And one of the things that I wanted to highlight is the current challenges that we've been having with specimen procurement. There's been so much interest and demand in biospecimens, especially now that pandemic limitations are a bit more relaxed. But what we're still seeing on our side is having difficulty ramping our operations back up to what they were pre-pandemic. So one of these challenges has been pandemic protocols limiting patient interaction for research. We used to consent our patients face-to-face in clinical spaces, and that was something that we were unable to do for quite a while, and we pivoted to remote consent. So we started calling patients on the phone, explaining the biobank process, waste tissue donation to them. And what we've noticed is that remote consent has significantly reduced our enrollment rates. When we were talking to patients face-to-face, our enrollment rate was about 95%. Now with remote consent, it's been about 40%. So we're looking into opportunities for improvement, whether that's somehow improving our consent process remotely or going back into the clinical spaces so that we can speak to patients face-to-face. And the other challenge that we've seen is that our ORs in our hospitals are operating at about 30 to 40% capacity. The hospital lost a lot of staff during and not after the pandemic. We're still in it, but there's a shortage of pre-op staff. There's a shortage of OR staff, surgeons, post-op providers. There are just staffing shortages across the board, which means there are fewer surgical procedures to screen, fewer patients to speak to and consent, and fewer, at the end of the day, fewer cases that we're able to collect on. And this is my last slide. If you are interested in more context or detail, or if you have any questions outside of the Q&A, you can visit our webpage or feel free to reach out to me or the medical director.
Thank you, Jenny, for a wonderful presentation. Any questions? Okay, I have a few.
Okay.
So do you have any advice to the companies on how they can make sample requests more feasible or more realistic? For example, the time limits, quality of material required, etc.
Oh, that's a really, really good question. So I think that in terms of feasibility of requests, two big main things. The first is that the is the size of the sample that you're requesting. Another trend that we've seen in our screening and consent process is that, especially for cancer indications, masses are smaller because cancer screening is better. Patients are getting treatment sooner, which is wonderful. We love to see that for the patients. But what that also means is when it's time for them to have their surgical resection, the tumor that is being resected is smaller, which means then a greater proportion of that is submitted to pathology for clinical care. And then a smaller portion, if any, is released to research. So my one piece of advice to anyone requesting samples is to really optimize your protocols to work with the smallest sample weight possible. Because sometimes there are requests where we see the cases and we get the tissue, but it's just not enough for what they're asking for. And then the second one is ischemic window. Sometimes people are requesting samples that need to be processed within 15 minutes or 20 minutes from time of excision. And that's very hard to work with because a lot of the clinical contingencies are out of our hands. So if you're able to optimize your protocol to work with tissue up to an hour past time of excision for processing, then that is really like kind of the sweet spot.
Okay, so there's one more question from Katie Green. So do you have banked collections of many different tissue types, or is it collection mostly prospective based on requests made?
Oh, that's a great question, Katie. We have both. So our specimen procurement BioNet team, they are the ones that do prospective collections. And then on top of that, they are also screening and consenting patients for our biobank. So almost every day, we're doing just as many prospective collections as we are collecting and adding to our biobank. And we've been doing that since 1996. So our biobank has about 70,000 samples, FFPE, frozen, across all the organ systems, many disease indications.
Okay, thank you. And there's one more question. Are there differences between the requests from biotech companies on Biosample Hub and the requests you receive from academic partners or academic researchers?
Mm-hmm.
Are there any differences?
Yeah, that's also a great question. I think that the requests that we see from academic partners tend to be a lot more specific, and many times it's out of our scope, so it requires a lot of back and forth and collaboration to figure out exactly how we're going to support them. And then I would say that from business and industry, most of the requests I tend to see are for cancer indications, tumor tissue with matched blood.
Okay. Yeah, many companies also have tumor tissues with blood and serum.
Mm-hmm.
Yeah, requests. Yeah, I guess that's okay. There's one more. So from Priya, if you could start your biobank from scratch again, what one thing you would ensure would have to put in place at the start?
Oh, I love that question. It is very interesting because for this program, it was already existing when I came into leading it. And then my job right before this was starting a biobank from scratch. So having had both experiences to compare, I think that, and this is just a personal preference of mine, I would have started from a place with more concrete operational plans before kind of building out and like doing the things. So I'm being very vague, I guess, about this, but I find that there are a lot of historical contingencies with our program where maybe things were moved very quickly or plans were executed prior to solid like SOPs, quality control checks, all that sort of thing. My preference is to have all of that in place before you start on executing.
Okay, and I mean, continuing that question, I have a small doubt on that. So if you would have to start from the scratch, you would first need to see how many samples or what kind of samples you would have to, start up a biobank, right?
Yeah.
So the cancer samples or cancer-based cancer-based biobank, or be it a disease-specific biobank, you would first see the number of disease specimens or disease samples you would have, and then decide on which biobank to start. Is it like that? Or first you see all the quality controls in check, as you mentioned, and then see the number of samples you have and then start? So is it first the number of samples and then the quality check and things like that? Or is it the quality check and then the number of samples? How does it?
Yeah. I think first it would be defining the scope. Whether that scope is very small and is focused on a particular diseased indication or is very broad. Either one is okay, but just having that clearly defined scope first. And then I would say having at least a simple design of like best practices and quality checks in place before you even start collecting on the samples. And then knowing if those quality control checks are appropriate for the sample types that you're collecting. Because something that I see sometimes is that people try to implement like a one size fits all quality control check, especially when they're collecting on a broad sample type. And that works for the most part, especially if you have a really robust quality control system. But there's nuance. Different organs, different tissues behave differently. Some are more robust than others. I think that if you can kind of fine tune it to what it is that you're collecting and storing, that just builds for a higher quality system in the long run.
Yeah, I guess that's about the questions.
Yeah.
Okay.
Thank you so much, Jenny. And
Thank you.
before I close off, I just have a quick question, just a small one. So what kind of clinical information is like easier to provide, and which one would be more challenging?
Yeah, I would say that demographic information is very easy to provide because that's information related to the subject. Disease diagnosis is also pretty easy to provide. What's a little bit more difficult is when people are looking for treated samples that maybe the patient underwent not one specific type of treatment, but like a class of treatments. That's very hard to look for, and it kind of requires a lot of time digging into the chart because a certain class of treatments can have something like 5 to 10 medications that fit into that class.
Yeah,
So
I
you mean
understand.
checkpoint
Yeah.
inhibitors and things like that.
Yeah. We do get a lot of requests for checkpoint
we
inhibitors. So we're just trying to find a middle ground so we can provide ample kind of information, but also not too challenging for the biobanks